All right, hello and welcome to today's webinar on Health Access Rapid Assessment Tool for Post-Earthquake Reconnaissance. This is hosted by the Learning from Earthquakes Public Health Subcommittee. My name is Elizabeth Angel. I'm EERI's Communications and Program Manager. And before we hand it over to the speakers today, I just want to take a brief moment to talk to you about EERI, in case you're not familiar with us. So EERI is the leading nonprofit membership organization that works to bring people from a wide range of disciplines and fields across the world together to dedicate ourselves to better understanding earthquake risk and advancing earthquake resilience in our communities. So we have both researchers and practitioners and students coming from a wide range of fields tackling these questions. You can learn more about EERI and join us at that link there. I'll share that in the chat. And I also wanted to specifically mention our annual meeting coming up next spring in Seattle. You can find the website there or from that QR code. And tomorrow, I believe, is the deadline for those of you who are thinking about applying for registration grants for early career students or for those with financial need. So I hope you give the website a it's going to be a great event. We'll have a 2-day technical program put together by a member-led committee. We're also going to have an earthquake reconnaissance workshop, which we'll talk about kind of great tools and innovative techniques like these, as well as a full-day field reconnaissance exercise based on a Seattle fault scenario that I think is going to be really interesting. We're working on that in cooperation with the Washington Geological Survey. So on that note, I'm going to introduce today's speakers, and I'll just introduce everybody quickly now before we turn it over. We'll be hearing from Courtney Welton-Mitchell, who's an assistant professor at the Colorado Public School of Health, and who is also the co-chair of the Learning from Earthquakes Public Health Subcommittee. From Shaya Christensen, who's a recent master of public health, also at the Colorado School of Public Health, and who worked on the survey tool we'll be hearing about for the, this tool as her capstone project. From Ceferino, who is an assistant professor at New York University, also co-chair of the subcommittee, and who's been using these tools in the field in post-earthquake reconnaissance in Turkey. And then from Yvonne Merino Peña, who is a PhD student at the Pontificia Universidad Católica de Chile, who will be speaking. So I'm going to turn it over so that Shaya can share her screen and get started. Or sorry, Shaya will share the screen and Courtney will speak first.
Great. Well, thank you so much. We're all very pleased to be having an opportunity to share this information through this webinar with everyone. We're going to be talking about the process through which we created a health access rapid assessment tool for post-earthquake reconnaissance. If you could go to the next slide, please. So, before I get into a little bit more about the tool, I just want to mention, as Elizabeth said in the introduction, this is part of efforts through the Public Health Subcommittee. And this is a subcommittee that was initially formed in 2019 by the former chair, Nicole Ehret. And we're in the process of trying to grow the subcommittee and seeking new members. So if anyone is interested in participating in the Public Health Subcommittee, or maybe even just coming to the next meeting to see what it's all about, if you could drop your email in the chat or the Q&A, or if you prefer, you could reach out directly to myself or Luis. We're both the co-chairs currently of the Public Health Subcommittee, and we would love you to attend the next meeting. That next meeting is Thursday, December 7th, 12 to 1 Eastern time. Thanks so much. Shaya, can you go to the next slide, please? So as I mentioned, this was really, this tool, the evolution of the tool was really starting from the inception with Nicole Ehret's guidance through the Public Health Subcommittee, where we met as a subcommittee and thought, how can we use the social determinants of health framework to think about domains of inquiry in really earthquake reconnaissance, but thinking about the intersection of public health and engineering. So this tool that's really a framework has different components. There's a housing component, a water and sanitation component, living conditions, health services, employment and education, and food security. You can find this published framework or tool through DesignSafe, and you can see the link on the left-hand side of the slide, and this information will also be shared after the webinar. If you could go to the next slide, please. So when we take just the health services component of the tool, that's what we'll be hearing about today. So Shaya did her master's project on the refinement, evolution, and field testing of this tool, and has really tried to say, how can we move from this broader social determinants of health framework into a more specific, concrete, operational way of utilizing the tool in the field, basically. How can we operationalize some of these like broader constructs? So in the health services section of the social determinants of health framework, we have components related to hospital specifics, clinical services outside of hospitals, mental health, and other services. And these are some examples of these sort of broader questions within these domains. Next, please. So now I'll turn it over to Shaya, and she'll tell you about how she went from the health services section, broader domains, and this sort of 30,000-foot framework, if you will, to trying to get to something that could then be field tested, as you'll hear more from Luis and Yvonne about that, and how this tool was field tested in the Turkey earthquake. But really it's about providing concrete tools so that those involved in reconnaissance have something specific to take to the field with them, where they can say, how can we pull in the public health components and integrate that with our engineering perspectives? So thank you, Shaya, and please take it away.
Thanks for that great introduction, Courtney. So as Dr. Welton-Mitchell mentioned, in this next section, I'll be talking about how we took that framework developed by Nicole Ehret et al. And turned it into a rapid assessment tool that is ready for field testing. And this tool aims to assess post-earthquake impacts to hospital and health services. And I worked with Dr. Welton-Mitchell and the EERI Public Health Subcommittee as part of my capstone research for an MPH program at Colorado School of Public Health. And I'll be presenting about the process I used to solicit feedback from EERI members in order to create this tool. And then after that, Yvonne Merino Peña is going to discuss how she and Luis used a first draft of the tool on a reconnaissance trip in Turkey. So the goal of this project was to create a rapid assessment tool in the form of a questionnaire that can be used to look at the impact of earthquakes on public health services. And as Dr. Welton-Mitchell mentioned, we narrowed the scope to focus specifically on hospital and other healthcare provider services. And we want to do this by soliciting feedback from EERI members, specifically researchers with earthquake reconnaissance experience. And as this was a capstone project for an MPH program, we did go through an IRB process, and our main questions that we aimed to answer were, what do EERI stakeholders perceive to be the most important components of health or public health data that can support their earthquake reconnaissance and follow-up efforts? Second, of the health or public health data deemed to be most important, what information is most feasible to collect during earthquake reconnaissance? So recognizing that importance and the ability to actually collect that data are two different things. And then third, we aim to answer, how can we adapt the survey tool in order to make it most useful for interdisciplinary teams, including engineers involved in earthquake reconnaissance? And then fourth, we aim to answer, what are some of the best practices and ethical considerations that should accompany the use of this tool? And as this rapid assessment tool is really meant to be used in an earthquake reconnaissance setting. And as many people on this call know better than I do, earthquake reconnaissance is a very particular setting for research and data collection. In creating this tool, we really want to cater to the ability to collect data in that unique setting. It would be used in the immediate aftermath of an earthquake, within days to months, on projects that may be put together and deployed very quickly. And it has to be used in a short timeline. And so we wanted to make something that's grounded in what is needed by the research community. As Courtney previously mentioned, we really founded this project in Nicole Ehret's data collection tool, Post-Earthquake Social Determinants of Health Assessment, which provides a framework for types of questions to be asked to assess impacts of earthquakes within each social determinant of health. And in speaking with Ehret, part of our inspiration was that while the questions that have been developed here are important, they're more of a framework, and they could be further fleshed out in order to actually collect specific data and more standardized data. And the hope is that we can eventually create or source an appropriate resource that can serve as a rapid assessment tool for each social determinant of health category. So that neighborhood and built environment, social and community context, economic stability, education, access, and quality. But what we focused on, because we only had a short timeline of a semester, was to narrow the scope to focus on hospitals and health services. And once we narrowed that focus, it came to creating or sourcing a resource that could serve as that rapid assessment tool. And we know we aren't the first people to be doing research like this, and it would be foolish to start from scratch. So we looked for an appropriate questionnaire that we could use as is or adapt in order to collect data on earthquake impacts to hospitals and health services. And that's how we came to Judy Matrani-Reiser's work after the 2010 Chilean earthquake. Judy has created an incredibly thorough assessment to look at functional loss in hospital systems. And a lot of the questions that she asked and the research that she was gathering was similar to what we were looking to gather with this rapid assessment tool. And Judy really generously shared her research and insight with us. And one of the reasons that why not use Judy's work? We created something new because part of the feedback that Judy herself gave us about her own work was that her research was incredibly thorough. It took hours to fill out each table, such as the one on this screen. And she was dedicated to exclusively that during her recon effort. We're looking to create more of a rapid assessment style tool. And so we were really working on kind of that Goldilocks solution of creating a tool that allowed for more information collection and somewhat standardized data, but that could also be used on a much shorter timeline than that of Judy's. So we drew a lot on Judy's tool, but we adapted it heavily in order to fit within a shorter timeline. And so using Nicole Ehret's framework and then drawing on Judy's specific questions, we drafted a rough first version of what we're calling the Health Access Rapid Assessment Tool, version 1. And as mentioned earlier, we really wanted this to be grounded in the need a process of soliciting feedback that I would use to refine a first draft of this tool. And I did that through a mixed methods approach. I deployed an online survey for Earthquake Engineering Research Institute members that was also sent out to other affiliate groups such as Geohazards International and STEER. And that survey was meant for folks who had experience in earthquake reconnaissance. I then conducted in-depth semi-structured interviews and informal key stakeholder consultations with a small subset of relevant stakeholders, many of whom are EERI members with experience in earthquake reconnaissance. And then I had an unexpected addition to this process. So I began this research in January 2023, and on February 6th, a 7.8 magnitude earthquake hit Turkey and Syria. And so this caused us to kind of shuffle our timeline. While we were really hoping to create a tool based on this feedback, then be able to field test that tool. But instead, we were presented with a pretty unique opportunity to field test the tool early. And so two colleagues, Luis and Yvonne, took the original draft of our rapid assessment tool and adapted it for their research on a recon trip to Turkey. And this was a pretty unique opportunity to get feedback on how this tool actually worked in the field. And these two were included in the interviews and consultations. And so We then used all of this feedback from the survey, the interviews, stakeholder consultations, and the field testing in Turkey to edit and refine the tool into a second version, and then write a best practices document that hopes to guide future efforts. So I'll briefly dive into each part of this process and what I found, and then how it informed the creation of version 2 of the rapid assessment tool. So the first step was to gather quantitative data through a survey. We had 90 respondents, used Qualtrics, and asked folks affiliated with Earthquake Recon to answer questions about their comfort level collecting various types of field data. And then we also asked them about topics of importance to them. And this survey showed that 96.77% of respondents ranked that gathering information from hospital staff, including administration, was either very important or somewhat important. We also found that 95.17% of respondents found that gathering information from community members who were affected by an earthquake was either very important or somewhat important. And what this tells us is that, like, I asked these 2 questions to gauge whether the people who would be using the tool see value in gathering these types of information, and their responses validated that. I also surveyed people about timing. The majority of respondents said they would be willing to spend somewhere between 30 minutes to 1 hour speaking with hospital staff. And so this gave me an approximate time parameter for the rapid assessment tool's use, and really forced us to edit the tool down pretty considerably. And then my survey also asked people about priority areas for data collection. The top priority areas for data collection that respondents ranked included explanations of how physical damage to hospitals is impacting operations, descriptions of infrastructure failures, mostly water and power, detailing how failures to backup power sources, including generators, impact patient services within a hospital, and then providing a comprehensive list of hospitals whose operations are impacted. And given the short length of the tool, I was able to use these responses to rearrange question orders in a way that reflected respondents' priority areas. The second part of the process was involved qualitative data collection and analysis. So I used free-form answers in the survey, along with interviews and consultations, to gather qualitative data. And this data was coded in Microsoft Word, analyzed for themes that supported and or contextualized the quantitative data, and then used to inform the creation of the second version of the tool. And it was also used to identify best practices in the use of the tool. And then this is where field testing of the rough draft of the rapid assessment tool in Turkey also came in. We were lucky to be able to send a preliminary version to Turkey with Luis and Yvonne on their trip in May. And while they'll speak more in depth about their reconnaissance and findings, I mention it again here because they're analysis process, and it was deeply informative for identifying further priorities for data collection, and really helped in like shaping the end result of qualitative data. I identified a few more priority areas for data collection that hadn't been identified in the survey. And that's mostly because they weren't options we were analyzing until they came up in interviews. So this included perceptions of safety. One example that came up over and over again was that often perceptions of safety don't line up with the actual safety of a building. So one respondent talked about a hospital in Baja California that was safe after an earthquake, but because hospital staff perceived the building to be unsafe, they were operating in a field hospital outside of the hospital building, introducing other types of safety concerns for patients. And in an opposite example that was provided by another respondent, staff continued to operate inside a building in Nepal, despite the building being near collapse. And this tells us that fear drives action, and perceptions of safety can be as important, if not more important, to delivery of health services and evacuation practices than the actual safety of a building. And so this told me that I have to ask questions in this rapid assessment tool that identify these types of perceptions of safety rather than just the safety of the building itself. The second priority area was accounting for non-hospital providers. So many respondents spoke about the need for the tool to look at a variety of health services, especially as it relates to the healthcare seeking culture of that area. And also to account for service redundancies. So in one example, a respondent talked about how outside of the US, clinics, private practices, or other types of providers may disproportionately make up the first response after an earthquake. And if the tool can't account for that or doesn't ask about service providers, research findings won't be able to accurately reflect the healthcare response after an earthquake or healthcare seeking behaviors after an earthquake. And this told me that any tool, such as the one we're trying to create that looks to assess healthcare services, needs to account for for a variety of provider types, and also needs to account for how people are seeking out care. So I made sure to incorporate questions about a variety of providers into the second version of this tool, rather than focusing solely on hospital services. A third priority area that came up through the qualitative process was the compounding effects of lost hospital services. And in the quote on the screen, this respondent was talking about the Paradise Fire, which is not an earthquake, but it was a pertinent example of how the loss of a hospital had compounding effects on employment in the town, which had an effect on the recovery process because people weren't moving back to the town if they didn't have a job at the hospital in town. And I think it's really easy to focus on the immediate use or non-use of a hospital, and that's definitely important in the short term. But loss of hospital services has so many effects on patients and populations in the long term. And what this told us is that we need to build in questions, probably open-ended questions that ask hospital staff and administrators about what they foresee these possible compounding effects to be. And then the fourth, I think we're on four, the fourth priority area was political context and building codes. Knowing political context and building codes can help to contextualize the healthcare effects that we find in our research. So I built in questions into the second version of this tool about political context and building codes. And ideally, this is something researchers using the tool would explore prior to deploying in order to contextualize the research they then do in country. And then finally, another topic that came up over and over again in my qualitative data analysis was the idea of difficulty in gathering and standardizing data in earthquake recon. And data collection can go out the window in a large event. Sometimes hospital record keeping systems are down. Record keeping can be deprioritized during a surge event after an earthquake. And this was important to us because I had originally drafted this tool using a lot of questions that revolved around numbers. How many beds are filled? What type of injuries are we seeing? How many of each injury type? But this feedback told us that these types of data may not always be available. So in the second version of the tool, I was able to build in a mixture of number-based questions as well as broader questions. And then another priority for me in writing this tool was to identify best practices for its use. So the following are themes that emerged from interviews, consultations, and written survey responses. First, many people gave me feedback that the public health and social science research, such as would be done with the Health Access Rapid Assessment tool, is best done on a later timeline than much of the engineering recon that happens directly after an earthquake. And this is because if it's done on a later timeline, hospital administrators and staff will probably have more time to talk to researchers. They'll have the space to talk to researchers, and researchers will be less of an imposition on their time. So what this later timeline is all kind of dependent on the scale of the event and the timeline for recovery. But we did find when Luis and Yvonne took this tool to Turkey, it was helpful that they were there months after the earthquake rather than kind of in that immediate aftermath period. And then a second key theme that emerged was the need to create multidisciplinary and diverse teams. So some ways that this came up for respondents was they mentioned the need for an interpreter in foreign language contexts. They mentioned the need for someone local to the context on the team. And they mentioned gender representation on the team. They also highlighted the importance of forming multidisciplinary teams and for seeking out interdisciplinary funding that allows these teams to go out into the field together. And the idea that public health researchers and engineering researchers can support each other's research goals and offer context to each other's research. And I think this quote highlights the importance of creating multidisciplinary teams. Multidisciplinary teams can collect better data because you're looking at it through multiple different lenses, and you're pushing each other to see a bigger picture. Then in a final recommendation, respondents highlighted the need for training for researchers who would be using this tool. And our survey data found that people would be more comfortable using the tool if they're trained on doing so. And then in interviews, respondents spoke about the importance of training all team members on social science interviewing techniques, whether those team members will be actually employing those interviewing techniques or not. So this idea that you may have social scientists going out into the field with people who are looking at purely structural damage, but being able to share, to know how each other's research functions in order to better support each other in the research process. And respondents highlighted the need for sensitivity and ethics trainings as well for working in sensitive fields like earthquake reconnaissance. Another type of training they talked about was wanting to learn more about how to write rapid assessment grants for multidisciplinary teams. And they mentioned that knowing more about how to write those grants will help engineers and social scientists alike feel comfortable seeking out grants for that type of collaborative research. And all this feedback told us that as we look to broaden the reach of the Health Access Rapid Assessment tool, it will be important to identify or create these training resources. And many of these already exist, but a next great step would be to compile a list of trainings that are appropriate or helpful for this type of tool, and then figure out what needs to be created to support the parts that don't exist. And this is also great feedback for engineering or for earthquake researchers in general, to seek out ethics trainings and to more often work on collaborative grant writing. A lot of our interview respondents just spoke about how they wished that they had more opportunities for that type of collaborative research and how much it enriches the research process. And then a number of other best practices were identified. So I drafted this document that will accompany the tool that outlines considerations for researchers or teams who may use the tool in the future. So where are we now? And what comes next? We used all of this data to draft a new version of the Health Access Rapid Assessment Tool, version 2, and a best practices document that accompanies it. And this will be posted along with this webinar on the EERI website, and then distributed further at a later date. It's important to note that this is an iterative process. We will continue to refine this tool as it's further field tested and as we gather more feedback on it. But for now, it's available. It will be posted along with this webinar and available for folks to reference, for folks to use. And then we also got so much valuable feedback on the process aside from simply creating the tool. So as I talked about in the last slide, I think appropriate training modules will have to be identified or created, and training recommendations will be passed along to any organizations that may want to use the rapid assessment tool. But in the meantime, this is meant to be a resource for the research community, and we really do want people to use it. And we want people to adapt it for their own research needs. So we're hoping this tool can be used to inform more complete public health data collection for EERI and to round out our understanding of health disruptions caused by earthquakes. And then finally, we hope to also apply a similar process to the other sections of the social determinants of health framework, and to round out a series of tools that can be used to really assess impacts to public health during earthquakes. Next, Yvonne is going to speak about the adaptation and use of this tool, as well as some other findings that she and Luis encountered on their reconnaissance trip in Turkey. So I'll turn it over to Yvonne.
All right, I think now it's in presentation mode, Yvonne. Thank you. All right, thank you, Shaya. I'm Luis Ceferino. I'm an assistant professor at NYU. And before giving the floor to Yvonne to explain the fieldwork we did there, I just wanted to mention that I'm also the co-chair of the Public Health Subcommittee, and we did this with a lot of support from EERI and also NYU who supported our trip. So with that said, Yvonne, let's go to the next slide. All right, so I was very fortunate because we got to the field work and we got to be part of an interdisciplinary team of researchers and engineers, and also a surgeon who went to the field and had the chance to look at the emergency response after the earthquake, with a lot of focus on healthcare. And we actually got to test the tool that Shaya described in the previous presentation. So the team was formed by myself. I'm a structural engineer. I also work on disaster risk analysis, also by Yvonne Merino from Pontificia Universidad Católica de Chile. She's a structural engineer, and also part of her research, a lot of her research is on healthcare infrastructure and performance. Sebastián Pizarro, who is an emergency surgeon. He's also a firefighter and does search and rescue. So it was great to have him on the team. Also, Luis Moya, he's from the Pontificia Universidad Católica de Peru. He's a structural engineer, but does a lot of work on remote sensing. So it's a very diverse team. And also Baturalp Ostur, he's a PhD candidate at NYU working on geotechnical engineering. So as you can see, there was a lot of expertise here from different areas. And we were fortunate again, we were supported both by EERI and NYU to travel. And also we received a lot of technical support from different EERI members who provided a lot of local contacts and also lots of feedbacks in our deployment plans, even before going. Okay, Yvonne, if we can go to the next slide. All right, so I would say unlike other reconnaissance teams, were focused on the infrastructure that supported the emergency response after Turkey. This was a massive event, so we were focused on different critical infrastructure that supported the first few days, in this case weeks, after the event, that the infrastructure systems and the government took to stabilize the communities. So in particular, we had a few overarching questions that we were aiming to address during the fieldwork. First, we wanted to see how the healthcare system that was significantly impacted absorbed and addressed or dealt with the large casualty surge after this earthquake. So we also wanted to learn whether these hospitals lost performance. And we were particularly focused or interested in the hospitals that didn't have as much structural damage, but whose non-structural components performance as well, decision-making from the staff were responsible, or were the critical factor in reducing functionality or taking evacuation decisions here. We were also interested in seeing injuries after earthquakes and understanding more the mechanisms of injuries. There were a lot of, I would say, non-ductile reinforced concrete buildings, 5-story and above. So we were interested in seeing what were the mechanisms there. We saw a lot of infill walls that potentially injured many people there, as reported in different interviews we had. We also were interested in search and rescue. We talked to firefighters and people who were in charge of rescuing people from debris after the earthquake. And also we were interested in different failures in the transportation systems that potentially disrupted the mobilization of patients. Once a hospital is evacuated, they have to send the patients to other functional hospitals. So we're interested in seeing what were the modalities there of transportation, and whether or not the transportation system was strong enough or redundant enough to support or sustain such mobilizations. However, today this presentation is going to focus a little bit more on the first two questions there. We're going to focus on the healthcare system because we wanted to see, or we wanted to comment more and describe more how we work with this tool for collecting such data. So if we go to the next slide, this is just a little summary. This was a mass casualty event. The total fatalities as reported were above 50,000, total injuries close to 100,000 people, unfortunately. We have reasons to believe after our deployment that numbers might be higher than this. But again, this is a summary of the official reports there. As you can see, the most affected areas were Hatay, Adiaman, Gaziantep, and Kahramanmaraş. We spent significant time in Hatay and Antakya, where, according to the official reports, unfortunately, there were more than 20,000 fatalities and more than 30,000 injuries. So with that said, I'm going to pass it to Yvonne, who is going to describe our fieldwork as well as our main findings.
Hi all, hi everyone. Thank you very much, Luis, for this introduction. Okay, well, our fieldwork agenda included these three cities: Adana City, Antakya City, and Kahramanmaraş City. And they are also provinces. They are the capitals from the provinces with the same names. We focus in this affected area. And for our case, in every city, we had the opportunity to visit one hospital and they perform very different in every city, and that was very interesting. We want to share some details with you in this presentation. Sorry. As already Luis mentioned, this is our team, our fieldwork team. We are there with the chief doctor, with the chief doctor and with the engineer manager from the first hospital, but that's just to show you the team. So we visited three hospitals, one hospital in every city. The first hospital was the Mustafa Kemal University Hospital. Just for you to know, to have a reference, the size of the hospital, it has 550 beds and 150 ICUs. It's one of the main hospitals in Hatay province. We visited in Kahramanmaraş province, that one on the eastern side of Turkey. It has 193 beds and 16 ICUs. It's a smaller hospital, but it was the closest city to the epicenter. And we had the opportunity to visit Adana City Hospital. That's a very interesting hospital because a couple of years ago, it used to be the largest base isolated hospital in the world. So it was very interesting. We had the opportunity to talk to engineers working on the hospital and facing the effects of the earthquake. Well, we visited these three hospitals, but there's a very interesting point here because we found one of them for the 3 hospitals we visited. The third one was a different case because we found this hospital from I mean, like a very unexpected situation. First, we went to look for the same like set of hospitals with the NESIP facility name, that is a state hospital in Kahramanmaraş, and it was closed. It had damage. We could see a bit of non-structural damage, but it was closed after the earthquake, and all the services moved to the building that you can see on the left. We were not allowed to enter this hospital because obviously it was closed. And behind this building, there was a new building under construction with base isolation system. But well, it's under construction. So I'm going to talk a bit about the way we apply this tool to collect data within the hospitals. This tool is a combination of different sources. It's adapted from the work from Shaya that she was mentioned before this presentation. It was adapted with some part of and some sections about the work from Dr. Judith Mitrani when she came to Chile and collect data about hospital disruptions for the 2010 earthquake, in the Maule earthquake. And we made some modifications, some adaptations, and we refined integrated all the resources, all the sources, and just applied a different tool, a modified tool that it has been like an input for Sasha's work as well. So the 4 sections that we applied on the field are mainly section 1 and section 2 that you're going to see on the next slides, adapted from the work that Courtney and Shaya were mentioning from the subcommittee, Public Health Subcommittee, and section 2 and section 3 were highly adapted from the tool from Dr. Mitrani for post-earthquake assessment of functional services in hospital. So now I'm going to share with you some details about our findings on all these hospitals. First, we visited MQ hospital, sorry. This was a very interesting hospital because it was the only functional hospital in all Hatay province after the earthquake. Some of them were closed, some of them were collapsed, and this is the only functional. It had no structural damage. It didn't have significant non-structural damage after the first earthquake, and it had totally functional services on the emergency department after the first earthquake. And the interesting point about this hospital is that it was evacuated after they call it the third earthquake, but it's an aftershock. It was on February 20th. It was evacuated, and then I'm going to share some details with you about the reasons for this evacuation. So here I'm pointing out the main building of the campus of the hospital. And then in front of this lot, this large lot that you're seeing on the left, we can see on the right a large lot containing the field hospital that was supporting the emergency department services after the third earthquake when they evacuated the hospital. And it also has temporary housing for healthcare staff, for administrative staff. So then we went inside the hospital, and it was very interesting because we found no damage. It was, I have some pictures as an example. This is the resuscitation room, one of the main or the most critical or more complex service room within the emergency department, and it was completely without damage, let's say. This is a picture from one of the imaging rooms. It has the X-ray machine, and it has no damage. And well, this is just an example of one of the corridors. Now, I'm going to show you what we found when we went to the upper floors. The last slide were about the emergency department. Most of the emergency department of the hospitals are on the first floor. So when we went to the upper floor, and we found that there was non-structural damage on the upper floor, on the last floor, on the seismic gap. So this picture shows like the only non-structural damage. This is the concrete cover detached from the walls and the structural column, the concrete columns. And in addition to this one, we saw on the first floor detachment of the architectural ceilings. So why I'm showing you these three pictures, because this one is like the summary for the evacuation reasons of the hospital. It was very interesting because they appear, all these, let's say, damages appear after the third earthquake, that they call it like that, but it's an aftershock. And this is why they evacuated the hospital after, let's say, 15 days. Okay, let's talk about lifelines. It was very interesting because they had, for water services, they had their own water source. It was underground water. So they didn't suffer like the outage, the water lifelines. The gases systems, all the medical gases systems performed well. They had power outage, and they take advantage of these 6 hours of backup systems of the power system, but then they lost again after the 6 hours. They lost the power, the electricity, because they were waiting for the fuel to come from a different province. And you can see on the right the image of the traffic the day after the earthquake. So this was like the main reason for them to transfer all the patients to other provinces. Well, also communication system also failed from the moment after the earthquake. About the services, we found that surgeries were all the time interrupted by the aftershocks during the 15 days that the emergency department was operating within the building. Surgeries were always interrupted by the movement, by the shake. The imaging services were also disrupted because the healthcare staff didn't use the services because of the fear from to go to downstairs with every single aftershock after the earthquake. Several amputations were like a very, very important topic that the healthcare staff shared with us. The medical staff were also victims, so some of them passed away, and some of them just didn't went to the hospital because they had lost their families. So human resources were also decreased in the hospital. And well, a very interesting point that they mentioned was all the non-injured people looking for other support services or just for help to the hospital. Well, about the operations, the hospital staff and all the patients, as I mentioned before, were evacuated after the third earthquake mainly because of their risk perception, as I showed you in the pictures. And the hospital is still now is operating as an emergency department, no more than that, in the field military hospital that I showed you on the pictures. Well, we applied how was the experience applying this tool? It is very interesting because it's highly the data collection is highly dependent of the survey respondents. So this one was like a very interesting case because we counting of the chief doctor and the operations manager that was an engineer. So we could go through all of the questionnaire, and it was very, very important for our data collection process. So we applied sections 1 and 2 that were about all the regional response and about the decreased capacity of the hospital. We went through section 3 and we collected data related to the demand, related to the injured people arriving to emergency department. And a very interesting topic that raised from this questionnaire application was that they had so many days before they could record the first information for the first patient. They took like 1 week, almost 1 week without recording any information about patient. About section 4, we had like a very general perspective because we were there like 2 months after the earthquake, about mental health. They were aware that they have like a very a waiting situation related to the mental health in the aftermath of the earthquake. Finally, we can say that I can see because of the controls. Okay, now I get it. So we can share with you that the vulnerable state of the respondent motivated to close the conversation after section 3, I guess, and section 4 was very general because of that. The application of this questionnaire lasted around 1 hour for this hospital, and well, we needed more space physical space on the paper to record additional information emerging from the conversation. The second hospital that we visited was a very different experience. This picture shows what we saw. We saw offices, administrative offices. We were not allowed to enter the hospital. We just talked to operations manager that was not an engineer, was not a physician. We didn't really know what was his background information, and we did it. So it was a very, very quick interview with the operations manager. That person gave few information details. We know that hospitalization services, as this was in Kahramanmaraş, the closest city to the epicenter. As a safety measure, they evacuated all of the hospitalization services after the earthquake. The patients were transferred to other facilities that were not the nearby facilities because they were also affected. That was a very interesting point. And the emergency department evacuation was also as a safety measure. They didn't experience any important damage, but they evacuated as a safety measure and returned the second day after the earthquake. And then this experience with Adana City Hospital, the hospital I mentioned was so big, the base isolated hospital. We have the opportunity to talk to a very interesting engineers team from the hospital. They have a unified engineering department for this big hospital, and they were talking to us about all general information about validating the functionality of the physical system, rather than looking through the affected services, because they were aware that services were going to continue functioning because of the seismically protected condition of the building. And a very, very interesting experience there was that the full post-circuit functionality just became the hospital a very critical point for injured people transfers from other provinces. So this was like the main story, and it was very interesting because they shared with us all this logistic information. We didn't even have space to record that, so we have records, audio records, but it was very interesting that this is a critical hospital on the network because it just continued functioning and it absorbed all the surging patients' demand after the earthquake that the other provinces could not absorb. Once the building safety was validated, they didn't communicate so much between the clinical staff and the engineering staff because, well, everything was working well. Okay, some recommendations for next field works are here. We want to share this with you. First, a multidisciplinary team is a very interesting advantage. It allows for a holistic view of the facilities, identifying the facilities, the services where to collect data, and it was very helpful communicating our interest and our objective of applying this tool through the multidisciplinary team because we have like the support of the medical disciplines. Reconnaissance fieldwork after the first stage of the emergency has passed helps a lot, helps collect important information without compromising the emergency response activities. It was very difficult to reach people during the first stage of the emergency because they were all like responding in the moment. We were there after 2 months from the earthquake, so it was very helpful. Local contacts are key to access the hospital, and knowledge about local context is also very helpful for visiting state institutions. In our case, it was very close to elections, and some healthcare staff, basically leadership, healthcare staff, were not so open to share experience because they felt compromised because of the elections, the near elections there. Lots of preparation should be done to find local contacts before the fieldwork activities. And this is the last one. It's very important for our presentation today because it's about the time that we need to interview the healthcare staff. It's very important to include time in interviews for introducing the membership, the member of the teams, for presenting our objective, for translating the questions and the answers, and some opportunities about collecting data from this type of tools is a better understanding of post-earthquake patient profile and the hospital resources needed to treat them, because they represent an input for a wider risk analysis model, not only the physical part that we have started all this present year, but translating those physical services into patients' demand for healthcare services is very important, and this type of data can be represent a valuable input for these models. And also, this data supports functionality models, hospital functionality models, through the use of post-earthquake hospital performance data. We have seen that there are lots of authors trying to model processes within hospitals and how physical damage is connected to functionality, to the healthcare services functionality. And this type of data is very useful to input these models. Also, studying diverse factors that trigger evacuation in hospitals with minimum damage. For example, we saw how human decisions are key to evacuate a complex hospital, even if they are supported by engineering experience. Sometimes protocols of fear or lack of awareness about previous experiences with great disasters can impact the decisions from the healthcare staff to evacuate the hospital. And finally, better understanding of logistic of patient transfers among the hospitals. When some points of the hospital network remain just closed or evacuated or ineffective. These pictures are showing, again, as I told you about the Adana City Hospital, this is showing how how this was a key point in the hospital network, because they received critical patients from other regions. And this is an example of how helicopters are key to transfer patients to functional facilities after other facilities have been collapsed or heavily damaged.
Great, thank you so much. If all the speakers could join us on screen again. So we have a number of questions. The first one is, how and why did comm systems fail? Was it due to power loss, internal damage, regional failure, or a combination? So I think this is for the folks who are doing the recon in Turkey, either of you.
I think there were a couple of slides more than we had. Just a couple more. No, I don't know if we want to put them. I can put them.
We just had a couple concluding slides. Shaya or Yvonne, could you just screen share again?
I can do it
share.
again.
Okay.
I'll do it. Now you can see it, right?
Great, right here, past the references, thank you. I'm just gonna wrap up with a couple slides here on behalf of the team. Again, thanks to Yvonne, Luis, and Shaya for all of the efforts that they've put in this process. I don't think I really need to sell anyone on the webinar on this concept, but we just wanted to end by underscoring why interdisciplinary approaches matter, and particularly when we think about, why does the Public Health Subcommittee exist within EERI? And I think it's because we want to provide not only that sort of multidisciplinary, but interdisciplinary broader perspective. And we want to be able to really meet engineers where they're at in terms of some of the needs that public health and more broadly social science can help to flesh out. So for example, when we think about questions of potential interest to engineers involved in earthquake reconnaissance that would require or benefit from an interdisciplinary approach that could be informed by public health and broader social sciences, we think about things like what factors influence compliance with evacuation advice when buildings are tagged as unsafe after an earthquake, including both residential buildings as well as hospitals, health clinics, and other buildings. We think about earthquake preparedness guidance, including implementation of building codes, securing items, creating a plan, purchasing insurance. Again, what are the sort of human and behavioral factors that can influence some of this? Also, response drill guidance during an earthquake, specifically advice to do things like drop, cover, and hold. When we look at the behavioral component and compliance, and we also look at health and risk communication messaging, this is something that I think it really just kind of elevates the discourse for us to have these interdisciplinary perspectives. And then finally, like response guidance in the immediate aftermath of an earthquake, things like, how do we motivate people not only to be educated about the importance of, but then enact the behaviors around checking for gas leaks, sewer leaks, downed electrical lines, and whatnot. If you don't mind going to the next slide, please. And these are just a few highlights of articles that are really taking an interdisciplinary approach around integrating epidemiological and engineering approaches, social technical approach for post-earthquake recovery of interdependent healthcare systems, and incorporating societal expectations into seismic performance objectives and building codes. If you don't mind going to the last slide, please. So again, we want to just leave you with sort of three big highlights. One is that you can access the social determinants of health framework and that sort of broader 30,000-foot view of the multi-sectoral tool that Nicole Arrett and colleagues have published. That is available through DesignSafe. Also, we will have the health services questionnaire. It's a modified version. So Shaya has adapted the tool based on not only the data that she collected, the quantitative survey data, the qualitative survey data, but also the feedback from Luis and Yvonne after the field testing. And we have this latest iteration that will be posted as a PDF on the EERI website. Again, that's a tool that's in process, but we encourage people to engage with the tool and think about ways that you might adapt it for your own use. And then finally, the Public Health Subcommittee, we meet quarterly, and our next meeting is December 7th. Please drop your email in the chat or the Q&A if you're interested in getting an invite to attend that next meeting. We would love to have you, whatever your background and interests, even if you just want to come to one meeting and see what it's all about. Thank you so much. And with that, I'll turn it back over to EERI and our colleagues to facilitate the Q&A.
Great, my apologies about that. So just to restate the question that I mentioned earlier, we had a question about comm systems, about how and why they failed. Was it power loss, internal damage, regional failure, a combination of those? So I think this is speaking specifically to the Turkish impacts you were looking at.
Yeah, maybe I can start on that. The comm systems, the one we saw in Hatay, in Antakya, in the Mustafa Kemal hospital, that one lost communications, but it wasn't. It was in addition to the power outages they had, so it was from the main system. We didn't survey the communication system itself, but that was what they reported. The doctors reported. Yeah, so unfortunately, we didn't check out the communication system itself. It was just that we checked that the hospital didn't have access to it.
Great. So another question, when you entered a damaged building, what was the first what you considered the most important indicator of damage that you were looking for? And also, what was the first question you asked people when you were interviewing them?
Yeah, it's a very interesting question. This survey we did was different from other more structural engineering reconnaissance I've done. So I think our approach here was to talk to medical staff and try to go through the survey as even a way to learn from the hospital in the first place. So that's what happened, for example, in the Hatay hospital, Mustafa Kemal hospital. And then after we got knowledge about the different components of the hospital, services that work and didn't, we did the structural inspection and went inside the building, usually together with the medical staff there. So it wasn't like a regular inspection in which we go and see like structural and non-structural damage in the building. It was more a conversation that helped us understand more the functionality of different hospital services.
Great. Let me see. Here's another one. Are you able to share some information about injuries that resulted from non-structural damage that you heard about?
I can share insights. Everything is a little bit anecdotal at this point. As Yvonne mentioned, hospitals that were had a huge load of injuries receiving patients. Unfortunately, it's reasonable, right? They didn't take records. They were focused on treating as many people as possible. So that side is hard. That side, I think the data has already perished. So we got most anecdotal evidence from doctors' reports and from doctors that told us more or less what services they got, what the staff reported to work, and what treatments they had to perform. So we got that information, but all anecdotal. It's in our documentation of the different surveys. And then also we went to see buildings and talk to firefighters. That part we didn't include in this session here. We saw a bunch of indications of people getting injured because of infill walls. In the reinforced concrete frames, we saw a lot of infill wall failures. You could see it. You can go into the buildings and see them on the ground. These are heavy, made out of clay. And we also got confirmation of those being injuring people from the firefighters that had to rescue people, many from corridors. We saw a lot of stairs, for example, that had lots of infill walls on top of them. So meaning that a lot of entry points were blocked when they were doing search and rescue. A lot of also exit points for people were blocked or people got injured there. That's what I can tell about injuries.
Great. So this is a question more about the tool in general. You talked about some training required for people applying the questionnaire, but would it be possible to disseminate this tool among some of the medical staff in hospitals in high seismic prone areas so they could do a timeline of emergency response before the teams for rapid assessment are deployed? Like that question about methods and options.
Yeah, I think that's not something that we have discussed, but I think that's a really interesting idea. I think it could certainly be possible. I'm not sure if the question is about deploying it in seismic prone areas prior to experience, that aren't necessarily in the immediate aftermath of an earthquake, or if this question is referring to sending it out to hospital staff before you visit on an earthquake recon post-earthquake. But I think either of those would be interesting. I think my main concern with trying to distribute it prior to going on a reconnaissance would be just that, like, hospital staff are so overwhelmed in the aftermath of an earthquake that like our as researchers, our priorities are not necessarily their priorities. And so yeah, it would just be important to keep in mind. But if you're already contacting folks in advance, or you have prior relationships with people who you will be interviewing, I certainly think a lot of it could be just filled out by hospital staff. But yeah, I mean, I think the most important thing that is kind of a consideration is just like, what are people's priorities, and what does that timing look like, right? And making sure as researchers we're considerate of the folks that we are asking to participate in our research.
Great. Another question, will the health services questionnaire be implemented into an electronic data collection platform?
I think that would be great. We are not at that point yet, but I could, this was a semester plus a few months long project. So making it into an electronic form wasn't possible during that time frame. But I think with more people working on it or the appropriate resources, I think that would certainly be a good format for its use.
If I could just speak to that, I think it would, there's sort of a range of things. You could build out like a whole app with different tools and components, or you could just very simply set it up in Qualtrics or Kobo or some other, mechanism, so that you could, even, for example, you could have Qualtrics offline app, and so that doesn't require connectivity, and you could have a tablet and just do it that way. So I do think an electronic version would be relatively simple to implement if we're not talking about a more complex app-based platform.
Great. A couple questions I just wanted to restate that were answered in writing. There was a question about architect, whether or not I think this is specifically about the assessment in Turkey, and this was answered in writing, but also maybe just for the team more broadly, about whether architects who are specializing in hospital functionality have been involved in this work, both developing the tool, but then potentially in some of the deployment of it in the field.
No, I don't think so. Not that I know.
And then also there's a question just about information developed by PAHO regarding evaluation of functionality of hospitals in Latin American countries. No. So maybe you could share a bit what that is for people who aren't familiar with it, and talk about whether or not it had a role in this project.
Yeah, well, we definitely, we read that literature. The PAHO has the Hospital Safety Index that rates many hospitals according to their structural conditions and non-structural conditions, also other conditions too. For example, I'm from Lima in Peru. All public hospitals, or most public hospitals there, have a rating, right? So it's usually very interesting, or it would be very interesting to see a contrast between what are the vulnerability ratings and what's the performance after an earthquake. For Turkey, we didn't have such information. One of the goals, we're still work in progress, one of the goals of our Public Health Subcommittee was to compile such information, so that if there is an event, we will have that information ready, which can be an early indicator of where to start looking for losses of functionality, for example, hospital functionalities. But that's the state of it. Yeah, for Turkey, we didn't find that information.
Mm-hmm. There's a question, I think this could, for everyone, whether or not you could suggest references to read more about this work. So I know you all shared reference slides, and we can probably make those part of some of the online resources that are made available down the road on the EERI and LFE websites about this project. But if there's anything you guys particularly want to shout out on to the audience here now that is valuable for both understanding the development of this specific tool, but also this field of research more generally.
To speak to the tool specifically, I think, again, checking out Nicole Ehret et al.'s social determinants of health framework kind of gives a really good reference and framework for how for both like what the social determinants of health are, which in public health research, like they're a very important framework for understanding people's experiences related to health, but also then to understand how that fits into earthquake reconnaissance and kind of the connections between social determinants of health and engineering research in earthquakes. So I think that's a really good, that's a great reference. Judy Matrani-Reiser's work is really great. And then Courtney shouted out that there are a lot of resources related to ethical issues and engaging survivors that can be found through the Converge training modules from the Natural Hazards Center. And I don't know, Courtney, if you want to add anything else to that.
Well, I would just say we do have some additional materials with the Public Health Subcommittee that are not published, but we could certainly share. And again, I would encourage people that might be interested in joining the subcommittee or just, you know, popping in for a meeting to do so. And we'd be happy to email some of those resources.
Great. And then we have a question about whether or not there are plans to share some more about this tool at the annual meeting in Seattle next year, for example, in damage assessment workshops or otherwise.
There are no plans so far, but that sounds like a great idea.
Yeah, we'll take that under advisement. We're still putting together the technical program and everything for those workshops. So the different parts of the Learning from Earthquakes program will definitely be having input into that, and we'll and some of the folks who I think at the University of Washington who've been involved in this work hopefully will be present at the meeting as well. So thank you for that. Great. And I just want to remind anyone else, we've collected a number of contacts that have been shared in the Q&A or the chat, but you can add in the chat right now if you haven't already, your name and email if you'd like to be get the info for that upcoming meeting of the Public Health Subcommittee, or just have further questions and interest in this work. And I'm going to share one more thing before we close here. So thank you to all of our speakers for this great webinar and for sharing this important work that you're doing. For those of you who've attended, I wanted to ask you to please complete the post-webinar survey. That should pop up in your browser, but you'll also receive it via email tomorrow. We really like to get feedback on these webinars to help develop our webinar program so it meets the interests and needs of our audience. You can learn more about EERI at our website with the link there. And if you want to support specifically the work that our flagship Learning from Earthquakes program is doing for earthquake reconnaissance around the world, donating to the LFE endowment is an important way to support that. And then finally, I just want to acknowledge that this webinar is supported with funding under a cooperative agreement with FEMA, as well as by EERI members like many of you and the endowment fund. So again, thank you for attending today. I'm just checking to make sure we got everything there from the Q&A and chat. Great, and I look forward to seeing you at future EERI webinars.